Good afternoon and welcome to our monthly breastfeeding webinar series. I'm Tina Cardarelli and I'm the Director of Breastfeeding Services at Indiana Perinatal Network and the Indiana Breastfeeding Coalition. And I welcome you today to our monthly series of calls. This month is November, an odd month, and it's a clinically focused call on the odd months. I want to thank our sponsors for this call. Newly added last month, the Michigan Department of Health and Human Services is now sponsoring our call, and we welcome those callers who are calling in from Michigan. It's exciting to have a broader reach, and we thank the Department of Health there for realizing the value of these calls. I want to thank the Indiana WIC program that's been a sponsor for a couple of years now, and St. Vincent's Health. So these calls are brought to you by the Indiana Perinatal Network and the Indiana Breastfeeding Coalition. Next slide, please. So I want to introduce our speaker today. That is a picture of Megan, except there's a thing over it. Okay. Our speaker today is Megan Glenn, and Megan is the manager of internal feeding program at Indiana University Health Riley Hospital for Children in downtown Indianapolis. In this role, she manages the milk lab and is also the coordinator of the on-site children's WIC clinic. I recently met Megan for the first time when we met to discuss the webinar topic, and I found her to be a very dynamic person who really loves her work and comes across. I'm excited to have her share her knowledge with all of us today. A little bit about Megan and her background. Megan has a degree in human nutrition and dietetics from Southern Illinois University of Carbondale. She completed her dietetic internship at IUPUI in Indianapolis and is currently halfway through her master's in healthcare administration. Megan grew up in Northern Illinois and her career background is in food service management. She came to Indianapolis 5 years ago to work on her dietetic internship, and we are lucky that she has put down roots and has no plans to leave Indiana. Outside of her very unique and interesting job, Megan likes to run, and last year she completed her first marathon. She is actively CrossFit and participates in Olympic lifting. So I'd like to turn it over to our speaker today, Megan Glenn.
Okay, good afternoon. Thank you for the wonderful introduction, and it is truly my pleasure to be here. I don't know if you guys can see the control panel on there or not, but I want to first apologize for the fact that I am a millennial and I am not technologically advanced. I'm technologically dependent. So if anything is to go wrong in the slideshow, or you see something or something pops up that's weird, I have an iPhone that connects to my Mac and turned it off and everything, but who knows what could happen. So like they said, my name is Megan Glenn. I am the manager of our milk lab and lactation services here at Riley Hospital for Children, and I am the Riley WIC office liaison for IU Health. Now, I'm sure a few of you are wondering what the point of a milk lab is, and some people might be wondering what a milk lab is altogether. So the main point of a milk lab is what we strive for in daily hospital setting every day, and that is patient safety. We wanted to have a safe, clean environment where we could prepare feedings with standardized practice and recipes. In doing this, we were able to give back nursing time at their bedside with their patient. A majority of our breast milk mixes come from our neonatal intensive care unit, or a NICU. And as we know, babies like this need more attention than other patients. And I'm not saying that they are more important. The point is that every mix in the milk lab is done with the utmost detailed attention, which is not something our nurses are always available to give when under great amounts of stress. So we took this stress off of nursing, and then we turned it into a state-of-the-art operation. And as a side note, I will be mentioning the F word throughout this presentation, and that word is formula. So after all, we do both breast milk and formula in this operation. So I don't want to throw anyone off there, but This will definitely have more of a breast milk focus. So I put a picture of myself on the presentation because once I finished my presentation, realized that there were no pictures of me, and then didn't think about the wonderful introduction I was given. So I awkwardly put a picture of myself here. But I want you to know that this presentation will be shorter than most. I am currently in the CLS program here at Riley. So this will be a short cover of what we do in the Milk Lab, who we have working on our team, what they do, and some additional services we provide. I'm also going to briefly touch on our in-house breast milk scanning system. So as you can see, hopefully at the end of this, you'll not only know what a Milk Lab is, but you'll be able to build one yourself or want to build one yourself. Okay, to start off, I'm going to have to talk about the most important part and people in my Milk Lab operation. These are my beloved team members who make the magic of the Milk Lab happen every day. Their backgrounds are mostly similar, but the requirement to work in the Milk Lab as an enteral nutrition specialist is to be a pharmacy tech, a diet tech, or have 12 credit hours of your undergraduate degree. It was for the previous years that we've been open, specifically a pharmacy tech or a diet tech, but recently in the last year, in order to get more people to get experience and be able to work in the Milk Lab, we expanded it to 12 credit hours for the undergrad. So everyone in here is a pharmacy tech except for Beth, who is both a pharmacy tech and a diet tech, and she recently just went to part-time to pursue her dietetic internship, and Krista, who has her undergrad degree in exercise science. So we're going to go through them here. The first one is Beth Walla, and then Krista Hammond, Rachel Meadows, and then Brenda Smith she's been with us the entire time, even when the formula room was open, so she's been with us for 15 years. Here we have Emily Werner, Meredith Marchand, Sophia Kim, Allison Radke, and Gabrielle Cruiser. So this is a kind of an important part. Together we have 5 full-time, 1 part-time, and 3 supplementals, and which puts us around the 7.1 FTEs, which includes my 1 FTE for the manager. And this is the only FTEs we have working in the Milk Lab. So the design team and creators of the Milk Lab include Dr. Engel, Dr. Poindexter, Cheryl Coveney, Kathy Mason, Jeff Ketchum, Wendy Cruz, our Riley IT and our IS team, and myself. So we have, as you can see, it was a small but mighty team. Cheryl and Kathy had the opportunity to visit Children's Hospital in Denver, where we got most of our layout and some of our daily process. And Jeff, Wendy, and I had the opportunity to visit the Michigan Mott's Children's Hospital, which I heard there are some people in Michigan listening. So, yeah, you guys helped us a great deal. We gained more of our daily process knowledge from Michigan Mott's Children. So, as I said, the Milk Lab was based mostly off Denver Children's, but we added some of Mott's daily process to fit our given FTE allowance that we had 3 years ago. So when we first originally opened, we had a plan of how many FTEs we wanted, ideally, to have in our space. And due to as everybody has probably experienced, how can you do the more for less? So we had to wither down our FTE allowance, which forced us to expand out to see Mott Children's area, which was a fantastic experience. And so that's why we took some of their processes. As you've probably figured out, we're located at Riley Hospital for Children with Indiana University Health. And within Riley, we are located on the 4th floor NICU of the Simon Family Tower. It has been about 3 years. The Milk Lab opens daily at 8:30 a.m. However, a Milk Tech is in the Milk Lab daily at 7:30 a.m. This person comes in and collects all of the orders off the printer for the formula. They set up their area for batch mixing, so they get their sanitation area ready, their blenders ready, their blender cleaning area. They turn the dishwasher on. They have cold water available and ready to mix, and all formula needed next to them on the cart, so that this is an easy flowing process. And then they complete the new orders by sending what we call a half batch to get the patient started. And then they complete the 24-hour batches that have been requested for that day. Around 1 p.m. daily, we mix the donor milk, and we make sure we do this a little later in the day so that maybe donor milk order changes have been finished, and this helps us decrease the waste of donor milk. And we know donor milk is very important and very precious, so we do not want to be wasting this resource. To backtrack a little, at 8:30 a.m., a second tech comes in and opens the window for mothers to drop off their breast milk for our daily use or storage, whichever one they need. As you can see on here, we are shut down from 3 p.m. to 5 p.m., and this is for breast milk mixing. Now, we have been trying to have 4 people lately in avoidance of closing down the window from 3 to 5, so that we can still get these mothers who maybe are coming in after work and things like that and want to drop off their breast milk, or maybe a mom who gets in at 3:30 and we could use her breast milk for the feeding for that day. However, when we do not have 4 techs, we close in order to have an interruption-free mixing process so that we can deliver and mix without any interruptions. However, as everybody probably knows, interruptions are inevitable, so we still have those. We have not been able to standardize our new hours with not closing down due to turnover, and this isn't a high turnover area. I don't want anyone to think that, but we do. I promote a lot of advancement. So if tech has their dietetic internship of their dreams, I promote that they go do that, and therefore they leave their full-time position. So, and we also had one of our techs just leave on maternity leave, which is wonderful. So we just have a lot of struggle with things like that. We open up back from 5 to 6:30 daily for any further needs that mothers might have in the hospital. So any more breast milk that they want to drop off, any utensils that they need, we reopen for that. And then I want to point out that we started a new initiative this year, and that was keeping fresh breast milk in the refrigerator for 96 hours instead of 48 hours. This has helped us alleviate the manual labor of thawing breast milk and having enough room to do so. And when I say enough room to do so, you will find out later that our space is somewhat limited, but we also have 2 scientific water baths, and when we have mixing up over 20 mixes per day, you can imagine that those scientific water baths get a little full, so this has helped greatly with that. So as I said, the formula portion of our operation is staffed daily from 7:30 a.m. to 6 p.m. Our formula service makes 24-hour batches of formula or tube feedings. We also do adult tube feedings for Riley Methodist University, North Hospital, and we sometimes provide for West if they have a formula that they have run out of, or a specialty formula. So it's not so much that we are helping our own hospitals in our area, which that is huge, but to know that this small service also helps, or is a total of 5 hospitals. We mix our donor milk after we are finished mixing the formula for the day, but before that courier comes to get all of their formula and donor milk for Methodist. Donor milk services are for Riley and Methodist only, because North and West, they all have their own. And we mix on average 75 mixes per day, and the batching process for formula and donor milk is in the first half of the day, so we do this right off the bat, and then we maintain for the rest of the afternoon, completing any changes or any additional feedings that are needed or new orders. In the milk lab, we have the first tech come in at 8:30 in the morning. They check for new orders and modify, create a thaw list, which is a list of all of the babies that we have and how much they are going to need thawed for the day. So even if they don't need anything, they make it on the list, and this is how we double check our work. Open and check the breast milk log, look for new drop-offs, round on nursing on other units, as well as the NICU to see if there are any questions we might have on the current patient orders. The second milk tech comes in at 10 a.m., and that third milk tech I was talking about earlier, they come in from 9 until 5:30. This person cross-helps both sides, so in the morning they stick with the formula side of the milk lab, and then they cross over to the breast milk side in the afternoon to make sure both sides are caught up and assisted when needed. And in the morning, the breast milk side maintains their area and assists hospital personnel as needed. And in the afternoon, they have their batch mix. So as you can see, the formula side and the breast milk side are pretty much doing the same thing, but at different times in the day, so they don't ever cross services. In the morning, they do have the occasional mini mix, which is when a baby has begun feedings or they went from a 20 cal recipe and they need to go to a higher level calorie of breast milk. We will do a few feedings to get them to their 24-hour or their new 24-hour batch. We only service Riley Hospital, and on average 25 mixes per day, but we have recently gone up over 30 mixes per day, which has been astronomical, and it's the highest that I have ever personally seen it in the 3.5 years that we've been open. After we're done mixing, we deliver the breast milk and the formula to clean utilities refrigerators on other units, unless these orders are from the NICU, and then we actually deliver those to the individual patient room. So the first thing on here is the CMV, and actually I'm going to cover that real quick in case some people are unsure of what that is, and I'm sure you all actually know. The CMV is a virus, and if a mother tests positive, she can shed that virus into her breast milk. We know that a large percent of women are CMV carriers, so we follow this freeze and thaw process to slow the potential CMV virus in this certain population. So the population you can see is on your slide right there. For the CMV policy, we fully freeze the breast milk for 24 hours and then thaw what they need for their mixes. We start the freezing after the first 7 days of pumped breast milk so the infant can receive all of the benefits from the mother's colostrum. Next on there are aliquots. If this patient is in the gestational age below 30 weeks, they qualify for what we call an aliquot, which means their mix is going to be placed into a smaller container with a syringe lid, so there is no chance of syringes being put into the bottle. We do not want anybody to put in and draw up. This cuts down on that contamination in those higher risk infants. If the patient does not fit in the above two categories and only needs 20 cal breast milk, this process can actually be kept in the patient's room. The milk lab will send labels for the 20 cal breast milk to the unit or the patient room. The nurse will then take the order labels, which we'll go over here in a little bit, and adhere them to the feeding bottle. She will scan the order to the babies to make sure that both of them match. And it'll actually show a match in Cerner, and then she can feed the baby. So we do not want any sort of feedings to happen without this double check of scanning first, because by having the milk lab and the scanning, we've taken the nurse away from having to constantly be away from the bedside, or getting another nurse away from their bedside to double check. This is what this scanning system is for. 20 cal of breast milk in these situations pretty much only comes to the milk lab for storage purposes. So no matter what unit or floor you're on, we will still fully accept you to come and drop off your breast milk if you would prefer to store it all in one area. In order for our team to get their daily tasks done efficiently and safely, mixed for our patients, there needs to be some order of operation. We must have orders placed in Cerner daily by 1 p.m. This is very similar to TPNs, and this is how we know who is eating and what they need for the next 24 hours. So anything after this, we'll go over here in a few minutes, but it gets a little more complicated and throws us out of our process. We take this time between orders and the label print off. As you can see, the label print off's at 2. to modify and cross-check our work to make sure recipes were entered correctly, and we have not missed any patients. And like I said, at 2 p.m., the labels print off, and during this time, breast milk is thawing in our scientific water baths. When they are done thawing, we tag them with what is called thawed labels. This is so that we don't confuse any thawed breast milk with any fresh when we put it back into the refrigerator. And also, this means that during mixing process, we want to make sure, you know, we use fresh. We want to use the fresh, of course. But if we have thawed some of this mother's milk, we're going to use the thawed and then use the fresh so that we're not wasting any of her breast milk. And so we need to be able to differentiate between those. We then place the mother's breast milk into the matching patient bin. And then I assure you after there is a scanning when we take it back out to do the mixing, and make sure that all of those bottles scan against that bin to make sure that, again, that's the right breast milk for the right patient. And we then go through our fortifying process with our breast milk scanning system, and then we deliver. So here are a few pictures of the Milk Lab, just in case some people I know haven't been able to come and visit, and I would encourage anybody to come and visit if they would like. You can kind of get an idea of what our space looks like. I know that's very difficult on a PowerPoint, but we have a triangle room, and really my only feedback as far as building a Milk Lab would be to not have a triangle room. It is a nice, cozy little corner in the unit, and it is just that. It is very cozy, but as we all know, when you have a triangle and you put things like a rectangle mixing table in the middle of it, you start having wasted space. So we have a lot of what we would like to turn into usable space, and we haven't quite figured out how to do that yet when you're in a triangle. So in these pictures you can see there's the window where the mother comes and drops off her breast milk. And Emily is right there in that window. They just come up to this and they drop off and get other things that they might need. And then our breast milk refrigerator, you can see this, how when I was referring to bins and breast milk being scanned into the bins, you can see there's little breast milk bottles in those bins. Each patient has their own bin. There is no sharing. This, our mixing area for our breast milk, is divided. You can see the centrifuge there in the background. And then our centrifuge for skimming breast milk, which is brand new to us this year and one of our most fantastic things we could have gotten. It took us from a skimming process of 4 days to 15 minutes, so it's been huge and enjoyable. And then our water baths there are located between the hand washing sink and then our sanitation sinks. In these pictures, you can see the other half of the giant mixing table. When earlier I said formula stays to one side and breast milk stays to the other, well, literally formula stays on the other side of the centrifuge. So it's not like there's anything wrong with mixing on the other side if need to. Our space is our space, and we sanitize very well. So if we need to carry over to another side, it's not that big of a deal. But it just works out very process-ridden that if you have your own space and area and what you need in that area, there's little reason for you to go outside of it, and fewer steps for my milk techs. Our formula refrigerator, so there is an entire separate refrigerator for the formula. One half of it is formula divided out into units, and then the other half of it is sterile water, which is that cold water I referred to earlier that we do our mixing with. And then we have our pasteurizer and dryer. The dryer is absolutely a great piece of equipment to be able to have all of your utensils dried in a sterile environment and not sitting out and waiting to air dry. And then on the back there is that F4 formula. That's our only stock that we have. It sits all on this one metric cart on the back wall by the formula. We work on a just-in-time ordering, or JIT, which is a lot of hospitals and organizations are trying to move to. So we try to keep on hand just what we need. We're not trying to have a stock room. We don't have a stock room. And actually, we would love one just to make some things easier for holidays and weekends. But this is our current process, and it works very efficiently. In this slide, you can see our penguin warmer. We use these specifically for mini mixes in the morning. And then on the other side of the stock wall, you can see in the middle there, there's some more sterile water that we move into our refrigerator. And then the breast milk storage bottles are kept there. In our back room, we have 7 freezers, which I will get to later as one of my favorite parts about the Milk Lab. And this is where we keep the breastfeeding kits for mothers. They're assembled and then kept back there, and other utensils for mothers. So in our Milk Lab, we have several supplies for mothers. So when they come, this is kind of like a one-stop shop. They don't need to wander the unit or ask their nurse where things are. They can come to us when we're open. We can get them their initial pumping bag, soap, bottles, lanolin, their patient labels, the dish soap, which is, we just got the actual dish soap, which we like, and the micro steam bags, and anything else that they are able or need. And then they can get all this when they come drop off their breast milk. So they really only have to come and see us maybe once, twice a day. We have also leaned or organized our space so that all mothers' lactation needs are right by the window, so that we can get these parents and staff what they need faster. Also, there's the map. It's the official map of our NICU, and you can see where the Milk Lab is located because it is circled in red on the map. And we are that triangle, and we have a vestibule spot in the front where parents, that's where they come in and drop off their breast milk. Now, that area is also where we have their breast milk storage bottles, so they can come and get those at any time of the day. And they also have microwaves and a sink in there so that they can come bring their parts and use the micro steam bags and everything. We highly encourage them to do this throughout their stay. We have several means of nursing and milk tech communication. They are available by phone, nursing coming to the window, or Vocera rounding. And this is where we find out what the patient's needs are for the day. If they're going to be missing a few feedings, keep an eye out for an order change if we need to be a heads up looking for something. Are they going to be short, and what they're going to need as far as an overfill to make sure that they have enough breast milk for tubing and we're not wasting breast milk. We also use huddles and discharge rounds to communicate probable movement of a patient, whether it be a transfer or a discharge to home. This is when we prepare the parents, and really we try to, if the parents aren't there, we prepare nursing by telling them how many bottles they have in our freezers and inform them that they need to bring a cooler to take home their frozen breast milk. And then, like I said, we also inform nursing, and nursing needs to let the parents know that they need to bring a cooler, and then they need to inform us when the parents are there with the cooler at what time the baby will be leaving the hospital. We don't want to pack up the breast milk too soon or not soon enough and have them come to the window and say, with their baby and their red wagon, and say, we're on our way out, where's our breast milk? And have us stop all pieces of the operation and pack up their breast milk. During that pack up of their breast milk, we also scan each bottle that they have in the storage and then pack it into the cooler so that we know that each bottle that they're taking home is also their own. Okay, down to the IS interesting part. I find this part very fascinating, and we have put a lot of work into it. In our Milk Lab, we have an internal scanning system, which means instead of buying a scanning system, we had one built through Cerner with our IS and IT team. There are 3 different types of labels that are used for the breast milk, and there is another label used for formula and donor milk, but I did not have that one shown in any of the upcoming pictures. The above label is an ID band label. This label is what we print out in sets of 10 for mothers or parents or whoever comes to the Milk Lab. These labels go on each individual bottle of pumped breast milk with the date and time that the breast milk was pumped. If there is no date or time, we will go find mom, or if she's still there, ask mom to write down what date and time that this was pumped on the bottle, and we can usually have a good idea dependent on the date and time of other bottles she has dropped off. But if she's unsure and knows it was used in the last 96 hours, or even if she's sure but it was done, I guess in 96 hours would kind of be our cutoff. We'll mark these as home use so that we'll put them in the freezer and she can take them home. We don't want to tell her her breast milk's expired or anything that isn't true when she could potentially and would still use this breast milk at home. So we just save that for later, and she can go ahead and take it when they transfer to home. And that way, they'll still have some, and sometimes that's the only breast milk they have when they go home is their home use, but it's kind of like a nice little surprise. The order label is what is placed on the prepared milk prior to delivery with additional order labels. So these are scanned prior to administration to document in the MAR, and for MAR for us is kind of where we timestamp that we have fed this feeding. This goes into our medications. So technically all of our breast milk orders and everything live in the medications in our Cerner process. And this is how they get that timestamp and how they get this barcode that needs to be scanned. We have to make sure that we document in the MAR that this feeding matches the baby and it can be fed. This label needs to be scanned with the ID label on the patient to make sure that the baby and the feedings are identical match. The extra order labels in the Ziploc bag that we send our 24-hour batch in are to be adhered to feeding syringes, bottles, or whatever they use, again, for feeding, to be scanned with the ID label at those other feeding times. Similar to the order label, the transport label lives on the bottle, or if this is an Aliquot, the smaller bottle, it lives on the transport. The transport label lives on the bag that the breast milk is delivered in, and the order label goes on the Aliquot bottle. There's not enough room for both when they get that small. This label is for the milk lab use only. When we drop off the breast milk into the patient's room, we personally scan this label with the patient's ID band to make sure that we are delivering the right breast milk to the right patient's room. So as you can see in this whole process, there are many times where we are double checking, triple checking to make sure that this is the right breast milk. And you can see the placement of the label in the picture. Note that the transport label is put on horizontally and the order label is put on vertically. The barcode is also on opposite sides so people can tell which one is their order one and which one is their transport label. However, they should not be scanning the order label on the bottle. They should be adhering their extra order labels to their bottles, syringes, etc., and scanning those. So as I said earlier, the purpose of the milk lab is to ensure patient safety. It is to make sure that the correct human milk goes to the correct baby while processing and fortifying in a centralized fashion following best practice guidelines. It is also to give nursing crucial time back to their patients at bedside. And as we know, there is a chance at any time, there's a chance for an infant to receive the wrong human milk anytime the express human milk is dispensed and it is taken as from the breastfeeding into the pumping and turned around. So the milk lab is entirely here for that detailed attention to make sure that we are constantly working that this breast milk never goes to the wrong patient. So during mixing, we do wear gloves, we wear hairnets and gowns every time we do the breast milk mixing. For formula mixing, they do wear gloves and hairnets. We change our gloves and wash our hands before each breast milk mixing. We also wipe down the counters with the purple sanitizer wipes, and then we wait 2 minutes. And during this time while we're waiting, we will scan for the next baby. Like I said, you take them out of the bin, scan all of the bottles to make sure that this is the correct breast milk we're about to mix. And then we move on to the next baby. During mixing, we do a double check to make sure that we scan the matches and the patient recipe page, and this matches the labels that we have for our 2 p.m. printout. So we take the labels that have printed out, we have the breast milk all scanned, and then we have the patient binder open to see their recipe and everything we need to work on. One tech will then read the MRN off of the patient binder, while the other tech checks all of the labels to make sure that we're all on the same page and we're all on the same patient. We have to do all of this before we can take the breast milk and pour it and start weighing it out and making our mixture. As a side note, you can see the list of equipment on there. And as you have learned from the pictures, this is not all of the equipment we have in there. There are obviously many more pieces of equipment than listed. But I'll have to say, and I said it kind of earlier, my biggest appreciation in the equipment are the freezers and having the freezer room. 7 freezers sometimes almost isn't enough. And so I am very thankful that we have at least 7. And then on every patient unit that we service, they also have a freezer. So if there is an overflow and a patient has, like we've had patients who take up a whole entire freezer and start going into another freezer, we can take these other patients and move them to their unit freezer and go get frozen breast milk as it's needed. And it makes a lot of difference to have all these freezers in their own separate room. There's higher ventilation in there so that these freezers never overheat, which has been great because that doesn't cause us any problems of having to call maintenance and having them in there when we're supposed to be mixing. But they're also very loud, so it's nice to be able to just shut the door and cut out some of that white noise in the middle of the day. In both areas in the milk lab, the breast milk and the formula, we work out of a recipe book. This is where we can have all different recipes for different types of fortifiers and formulas in order to get our breast milk from 20 cal to 22 to 24 to 27 and to 30. These are all the calories that we make. These are all standard recipes made and updated and graciously distributed to us by our NICU dietitian, Wendy. We weigh out all of our fortifiers and formulas on an electronic scale to make sure that we're getting the precise amount for our mixes. As I said earlier, all of our orders live in Cerner under the Milk Lab care set. We have worked on improving the usability of these care sets over the last 3 years, and finally at the end of last year, we got them to an easy usability point. At the very beginning, these orders were not able to be modified, and the provider actually needed to have the recipe in order to place their order, which imagine being a provider who never needed this to all of a sudden needing to know how to mix breast milk and then having to put that into our order so that we could mix it even though we already knew what the recipe was. So 3 years later, so now we're to where we're at now, the orders are modifiable and providers pick their fortifier and fill out their volume or rate, and dependent on the care set, there's intermittent and continuous care sets, and they hit sign. So this went from a 15-minute process that was very disruptive to our providers' daily flow down to a 15-second process. They can modify their orders any amount of time, and each time the Milk Lab is notified of this change due to a printout that kicks out into the Milk Lab off of the printer, so that every time they modify the notes or place a new order, we are instantly notified about it. Also, this past year, we got a centrifuge, which I mentioned earlier, and you saw a picture of, and we are now able to skim breast milk. So we were able to get a skimmed order care set, which proved itself to be very important because there was starting to be this confusion of 20 cal in a skimmed, and it would say skimmed breast milk, and we don't know if they meant do you want just the skimmed breast milk, which could potentially be down to 10 cal by now? Or are you looking for us to skim the breast milk and bring it to 20 cal? This was creating a lot of confusion and some errors, so we got our own care set built. So we now know that if it's going to be 20 cal, it needs a fortifier. Finally, we have our after hours process. Do not take calls or orders after 5:45 p.m. The answering machine and Cerner lets the provider know that they are too late putting in an order. And if the formula is a standard in-house formula, they are requested to feed the formula's equivalent ready to feed throughout the night until we can get their higher calorie equal. And we deliver that in the morning in that half batch I talked about earlier. So for special orders that do not come in ready to feed fashion, the provider needs to fill out a form, scan it to the pharmacy, call the pharmacy to make sure that they got it and understand the order, and then pharmacy fills that order overnight. So as you can imagine, I try to avoid that. It's not the easiest process to remember at all times, but the form lives on the Pulse page, and this is their one way to get these formulas that they need all through the night. For donor milk, there's currently no standing after hours process. At Methodist, we have stocked them with their own 20 cal donor breast milk that they can use overnight if needed. They were originally requesting this for the after hours, and if there was a hypoglycemic baby, they were born, and mom's breast milk wasn't in, and they would want to use donor milk. They didn't have any. So we started sending over stock bottles for them to use. And at Riley right now, there is no way to track how much was taken and what unit to charge it to, since we charge individual units for their donor milk. So they cannot remove the donor milk from the milk lab overnight. Now next year we're centralizing how we charge out our donor milk throughout the hospital, and we're having that cost come specifically from the milk lab cost center. So this could lead to the potential of an after hours process, because we would know, all we would need to know is how much went out, and we would be able to charge that. And obviously we would need to know what patient it went to for follow-up the next day, but it wouldn't be so based on a we don't know who to charge piece. So I could see that becoming a very thorough after-hours process. And then for breast milk, our after-hours process is to use mom's 20 cal breast milk. If the 20 cal order needs to be placed, and this is that confusing part, at somewhere between 2 and 5 if they order. And I say 2 and 5 because our label printout is at 2. And that's when our process really kicks off and starts going. And it becomes dependent on the case and how many techs are working that day if we can adjust our process to make this late order. So really after 5 p.m. a tech goes home, and we're really down to a point where we cannot mix late orders unless they are an absolute emergency, and then we'll ask the charge nurse for help. So in some cases we can help them later on, but unless that doesn't happen, then they will need to feed this 20 cal overnight, and in their order they're going to put that this is 20 cal specifically for the overnight process. Please get your fortified breast milk from the milk lab in the morning. And then that way we will know, and the nurse will know, that they need that breast milk first thing in the morning. If there is not breast milk in the patient's room, the NICU charge nurse can come into the milk lab and get some fresh or frozen, and then they need to document this next to the door. We have a form of whose breast milk was taken out, how much, their MRN, and what time, so that we can track and help them again in the morning. Then in the morning, the nurse also needs to call the milk lab and let us know that she needs fortified feeds for the rest of the day. So as promised, this was a rather short webinar, but this is where I will open up, or if there's any questions, but I also want to leave my screen up or just here for a minute with my email. So if anybody has any further questions along the road to follow up, or would like a site visit, I would encourage you to send me an email. I'd be more than happy to talk to you, contact back.
Megan, this is Tina, and we do have a couple questions.
Okay.
And so the first one is, what references and or resource did you use to make your freezing protocol for CMV? Do you do this for all babies under 32 weeks or just for any babies of moms who are CMV positive? Do you continue freezing for the entire stay, or do you give them fresh after they reach a certain gestation?
Sure. So I should have, if I was really good at this, I would have brought the CMV policy with me. Kathy Mason is kind of our champion on that, so I'm sure she could help with further questions after this, because I know I'm not going to answer your full question. So we do the CMV policy. I think it was on the slide. Let me look. So the CMV we do have here as a policy, and we, however, do not have to follow it if the provider does not want to, or if mom is breastfeeding. So if mom is breastfeeding, we're obviously not going to tell her that she cannot do that, and we need to take that and go freeze it. And I can't find it. But if the provider also doesn't think that this baby holds a huge risk, or they want to do something else, then we also don't, they can nix this protocol as well. Here it is. So we freeze after, like I said, after the first 7 days, and then the duration of the freezing is for 8 weeks. So after that 8 weeks, or they become of term, we will stop the freezing process. And then I forget what the other part of the question was.
Oh, yeah, they asked you if you do it for the entire stay or if you give fresh milk after they reach a certain gestation. So you answered that.
Yep.
Okay. And then another question, have you realized a decrease in your infection rate, particularly neck, since you went to milk lab preparation from bedside prep? That
was one of our largest reasons for getting a milk lab, and I can say that I do not track that because I'm not always aware of what babies have neck and where it was caused. So I don't know if there has been a decrease. I would like to assume that there has, but that can be another question I can ask our medical director and get back to you with.
Okay. Well, I would suggest that the person asking that question or any of the questions contact Megan directly, and she can talk with her medical advisor, medical director.
Mm-hmm.
Okay, I have another question. What kind of Joint Commission regulations does your milk lab have?
These are very good questions, and I just had a visit.
Okay. They're hard questions.
They're hard questions, and you know, in the middle of this week, anything's hard. So they pretty much came in and looked at our documentation that we have, how we double check. They asked a lot about our double check process. How we know what patient we're on. We just talked to them about the scanning system, and we had it ready pretty much like we would for the State Department of Health, anything that they'd want to see as far as temperatures documented. But really this time that they came in, their largest interest was how we know we have the right baby for the right patient. And then I think they were majorly interested in just seeing a milk lab. So we didn't have anything more specific than that. But we did get a shout out in the report out for being a very process oriented area, and that they appreciated that very much.
Wow, great. Yeah. All right, we still have time for a few more questions. What is your process for screening for drugs of abuse in breast milk?
So we're trying to pass a drug use breast milk policy right now. But if the mother, if this is a preterm infant, I believe it's under, and Kathy Mason's probably listening and going to be sad that I don't remember all of this, under 32 weeks, if it's a preterm infant and mom is positive just for marijuana, we will use that breast milk until the baby hits term, and then mom needs to test negative for any marijuana, any THC use. If it is any other type of drug, we will not use, or if it's a polysubstance abuser, we will not use their breast milk.
Okay. Another question. Some milk labs use a hood when mixing. Why did you choose not to use a hood?
There just wasn't enough scientific evidence for us to install a hood that it either helped greatly or it, was a negative effect on the quality. So we do have extra ventilation in the milk lab, so we have a higher airflow, so it's a little bit cleaner as far as what your normal mixing area would be, but it is not to the extent of a hood, and it was just because there wasn't any major backup for us to get one.
Thank you. Well, here's a question I actually can answer, but they want to know if Medicaid program in Indiana pays for the cost of breast milk preparation or any banked breast milk being used. And I can not yet, but we do have a task force that's working diligently on this question.
Yes, and we actually do not charge for breast milk mixing or formula mixing in the milk lab. So,
can you you touched briefly on just improving the flow and the environment and time that the bedside nurse has, and can you give any anecdotal kind of evidence to support like that the nurses like this better, or like what do they say, or how do they adapt to this?
Sure.
This centralization?
So this was a huge struggle for nursing when we first moved in, and it was kind of like we were taking away their baby from them. They they like that control to know what's happening, but I would have given it less than half a year, and you will have, especially NICU nurses, because we help every single baby on their unit, them say they will go out and advocate for us and say that the milk lab is actually fantastic, and that it gives them this time that they never knew that the mixing and everything took so much of their time, and it wasn't as precise as we do it. And we've actually had nurses come in and job shadow to see it, and they're just wowed. So it has gone from one, we don't like this, new process, new change, to we can't see it any other way. So it has been very positive. It just took a while to get there.
Right. Well, I think that's a good technique to, or a good way of creating attitude changes, just to say, hey, come and see what we do, job share. I think that was a good way of handling it. I'm just wondering, I don't know a lot about this process, and I'm wondering, in the water bath, how long is the thawing process generally?
So it takes about an hour for it to completely thaw. It doesn't sit at a hot or boiling temperature. It's just like a room temperature. It just slowly thaws that way.
Okay. And last question. So I imagine that you get a lot of breastfeeding and pumping questions at the window, and that's probably not the most appropriate time to answer a lot of questions. Yeah. And so what's the division of labor in your milk lab for making sure that parents get the kind of education and support that they need?
Sure. So if it is not a question that we can answer or is in our scope, if it's a question we can answer and in our scope, we will take that time to answer it. But if it is not in our scope, we have our wonderful lactation consultants right across the hall who some of the times will actually hear the questions and come save the day. But we will refer them to our lactation consultants, or we will page them to try to contact them or let them know that this mom has a specific question and she'll be here from, such and such time for the day. And the same with the dietitians. So if the dietitians have, if mom has a question and it's seemingly for the dietitian, we will page them, or we will, contact them and let them know the times that the mom will be there. So we're kind of a reference point for ancillary teams. If it's a social matter, we will do the same. We have social work contacts in there as well, or case managers for any aftercare follow-up that they might have a question about. We have all of those ready for them.
Great. Well, I can't thank you enough, Megan. This was really good. This is a whole aspect of breast milk feeding that I wasn't that familiar with, and I'm sure a lot of our callers aren't, although I'm sure we have a lot of people that are calling in, I can tell, that work in NICUs. And so this was a very valuable call today, and I thank you for your time.
Yeah, thank you.
Okay. So I want to thank everyone for joining us, and I would like to ask you to join us again next month. And actually, that date's wrong. It's supposed to be Tuesday, December 13th. So we realize that the third Tuesday of the month is actually the week of Christmas. So it's been moved up to December 13th from 2 to 3. So note that. If you have an interest in a community-based topic, and next month I'm excited about, because there are two women that have worked really hard to figure out how to better organize their local coalition. So they're going to talk about simplifying some complicated coalition processes, and also too how they really simplified applying to be a nonprofit. And I was really hunted them down for this topic, because we do get a lot of questions from coalitions all over the country asking about how they should structure themselves financially. So please join us next month for Anne Marie Neely and Marianne Martin, who will be our presenters. And lastly, I want you to stay tuned for many exciting changes on these calls in 2017. With Michigan as our new partner, we have expanded our audience to Michigan very deliberately. We have people call in from around the country, but primarily our calls will be focused on Indiana and Michigan. And we are working really hard to bring more free SERPs. Our goal is to provide them in 2017 for most of the calls, and CEUs for nurses, and we're actually even looking for credits for RDs and other health providers. So stay tuned for that. And then we are currently working hard we've done surveying, we've looked at the surveys that everybody filled out this year about what they wanted to hear, and we're actually involved in planning meetings to try to bring you the topics that you told us in the surveys that you most want to hear. So with that, I'll close out the call and say have a great afternoon, everyone.